Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello again, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is OB-GYN with Monument Health Spearfish Clinic. It's Dr. Heather Brewer. Thank you very much for joining me, Dr. Brewer.
Thanks for having me.
You bet. Today, the topic is going to be birth control. And I know a lot of people instantly think, well, I know everything about that. If you're an adult and you're of sexual age, of course, I'm sure you know, or you think you know all about it. But I imagine there's going to be a lot of info and a lot of things you can answer in this podcast for us.
Sure, I hope so.
Well, let's start off very basically with this: the different types of birth control. And I'm assuming we'll kind of concentrate mostly on women's birth control in this podcast. But I'd like to ask you about men's birth control too. Your knowledge of that, maybe
Sure.
as we wrap things up. So, what are the different types? We know the basics. But could you go through that for us?
Sure. So there's lots of different types out there available, from kind of the least convenient to the most convenient, sort of how I usually describe it to patients. The least convenient being, really, I guess that sort of adds in the male birth control. So
Sure.
Condoms are probably the least convenient in the sense that, you have to use them every single time. You have to have them available, that kind of thing. From a female birth control options, we talk about birth control pills. They are probably the most commonly used, and they're the most readily available, but they're the least convenient for women to use because they have to take them every day, and they have to remember to take them every day. They have a little higher failure rate just because they have to remember to take them, and if they forget, they don't work quite as well. But they are the most commonly used birth control out there just because they're relatively inexpensive and easy to get. And then there's a patch, which is a little more convenient. It's once a week. There's a vaginal birth control that's once a month. And they all kind of work similarly in that they're have estrogen and progesterone in them, and so they all kind of work the same, and they and so they're more kind of basic, something you have to do every day, every week, every month. And then we get into a little more convenience where Depo-Provera is a shot. It's once every 3 months. So that's a little more convenient for people who maybe don't think they can remember to do something, every day.
Right.
So that's a shot every 3 months. That has progesterone only in it. So for people who maybe can't take estrogen or don't like to, that's a little easier for them. That one they have to come into the clinic for, or some, go to a pharmacy or something every 3 months to get that one. And then after those, and we talk about long-acting reversible contraception, you'll hear the term LARC, L-A-R-C, which stands for long-acting reversible contraception. So it's a term that gets thrown around a little bit, maybe just in medical
Now, is this
circles.
Is this something recent? I've never heard of that before.
Okay, so it's not. Those aren't new. Like those are IUDs or the implantable devices.
Yes, okay.
Those are things that we advocate for a lot, just because the convenience factor. They're highly reliable birth control and also very convenient. So I think you see and hear a lot more about them now since the Affordable Care Act, because they're very cost effective and generally are also covered with insurance because of the Affordable Care Act. And so prior to that, they're pretty expensive, and so not a lot of patients had insurance that would cover them. And so now we probably see people using them a lot more because of the affordability of them. So IUDs, there's several different kinds. There's 5. There's 4 different progesterone secreting IUDs and one that uses copper. And so there's a 3-year, a 5-year, an 8-year, and a 10-year device. And so they're varying lengths of time. And so there's a lot of different choices there. And then the arm, there's one that's implanted into your arm. That's a 3-year device. And so the ease of use is great for patients so that we put them in for them. They don't have to remember to do anything. The effectiveness is obviously much higher because they don't have to remember to do anything. So we see much lower unintended pregnancy rates with those. And so we advocate for those a lot in all patients. It's something that usually high satisfaction rates with those. And so we certainly do a lot of those in our clinics just because they're, high effectiveness as well as patient satisfaction.
You're rattling off this list and trying to keep up with them all. No. This is great for my next question, because so let's say a woman comes in and she's ready to get on a type of birth control. If I was a woman listening to this, my head would have been spinning just a little bit, right? Because there are so many choices. So then you, as her gynecologist, how do you even start the process? How do you even start to tell her, this is the path you're going to go down?
So I would say, like, for most patients, if they come in and they're asking about what kind of birth control, they're not sure what they want. Sometimes they come in and have an idea, but usually I ask them kind of like what their goal is, how long are they thinking they want to be on birth control? Are they thinking they want to start a family in X amount of time? We look at any medical conditions they may have, because that may rule out certain kinds of birth control. Maybe, what their periods are like, things like that, because certain ones might affect and help, certain conditions are having. So, if they're thinking they don't want to have any children at all, or maybe they want to have kids in a few years, or maybe they're not, they want to have a baby in 1 year. Well, an IUD is probably not worth putting in for 6 months or 8 months or something. Those are longer acting things versus someone that knows that they, want to wait several years, then that makes a difference. There are certain medical conditions that we would not use birth control that contains estrogen. So people that have had blood clots in their legs or lungs, or things that you can't use estrogen in patients that have had those types of conditions, because it increases your risk of having a clot again. So we have to be a little careful in those situations. Or patients who have migraines with auras, those are a relative contraindication to using estrogen. So we'd have to pick an estrogen or a non-estrogen containing birth control. So your medical conditions do also factor into the choices. So you have to kind of look at the whole picture of the patient to decide, and then you kind of go with that route. Some birth controls help with PMS. So if patients have significant PMS, then we would maybe go towards a route that does actually suppress ovulation, like a birth control pill or the patch or something like that, whereas an IUD does not actually suppress ovulation in all patients. So it wouldn't really help them with their PMS or their menstrual migraines, but whereas a pill would. So there's some... It's a little complicated.
Oh boy, no kidding. Just trying to keep it straight. Be thankful that there are people like you out there that can put all this into perspective and help them out. But you said something interesting about how some of the medications you take can also have other benefits for women too. Now, do they find all this out in the trials and the studies for these, or is like, well, this medication we know works for birth control, and then these women are saying, but it also does this thing? Is that kind of how you learned
both.
About that?
Yeah,
okay.
Probably both. Like some of the things, some things probably in development where that they did it on purpose when they were making these medications, and some were probably found out later after they, developed the birth control, and then later on people said, oh, this helps with this.
What are some of the benefits you can get outside of that?
So, we have, certainly we have patients who have significant like PMS type symptoms that those can be helped with birth control that suppresses ovulation, and that gives them more of a steady hormone state every day. So pills, the patch, the vaginal birth control ring or Depo-Provera, or the implant in the arm, any of those could help with that type of symptom. People who get menstrually related headaches, that can help. Patients who have endometriosis, which is another medical condition. People who have really heavy bleeding or irregular bleeding, birth control can help with that. Also, birth control can protect you against ovarian cancer and uterine cancer. So those are things that also can be benefited from taking birth control. So
has there ever been a side effect that's really surprised you from birth control? Whether I'm totally blown away with the last two you mentioned about the cancers.
Yeah. I think that one surprises patients because there's some fear sometimes, and patients are worried about birth control causing cancer. People are worried. I think there's, breast cancer is always a fear of people. And
is it a legitimate fear?
That's a difficult question to answer. I mean, there are probably, some breast cancers are hormone receptive. And so there's always this concern of will birth control cause, and there's controversial studies out there that, I'm afraid there's probably not good data on that you can say with any certainty that birth control pills will cause breast cancer. But certainly in patients who have a history of breast cancer, we don't give them hormonal therapy. And so that's a difficult one to answer. But
sure.
But in patients who are higher risk for breast cancer, if they need hormone therapy, we still use hormones to treat them for other things. So that's a tougher one to answer. But we know it protects you against ovarian cancer and uterine cancer just by nature of how uterine cancer is caused by, too much estrogen, not enough progesterone. And so if we can balance those hormones, or ovarian cancers, one of the theories is felt to be that it damage to the ovary caused by ovulation. And so if you keep that from happening, then you're protecting the ovary a little bit. And so there is some data to show that they're protective in people that have been on birth control longer. In patients who maybe have a higher risk of that, then that can be helpful to them. So
well, and maybe this is a silly question then. Why would, if those medications can protect you in that sense, why would you want to use anything else?
Well, I think those, ovarian cancer is really rare. So, that's not, that's probably not people's primary goal. And so it just depends on what they're looking for. So some people tolerate some things better than others. So there are patients out there who have been on birth control pills and maybe they didn't like how they made them feel. And so they want to do something different, or, they'd rather have something that is just local effect, that they, like an IUD is a local effect to the hormone. They don't get much systemic absorption, and so they have less potential side effects. Also, the lack of estrogen in an IUD versus, if they have some of those other medical conditions where they can't take birth control pills with estrogen. That's another benefit. There's lots of different choices. So
now, one you didn't mention, and I don't know if I'm surprised that you didn't mention it, because it seems like it's a pretty it's a kind of a major surgery, but that would be having your tubes tied.
Oh, sure.
Is that
sterilization?
Yeah, I don't. But that's not. You wouldn't recommend.
It's birth control. Yeah.
Sure, in a sense, yes. But it's not really reversible, is it?
So it's meant to be non-reversible. We always counsel patients, if they want to have their tubes tied, that it is meant to be non-reversible and permanent. There are places in the United States that do reverse them. Although it depends on how you have your tubal done. It is... Nowadays, most tubal ligations or having your tubes tied is done by removing the fallopian tubes. A few years back, there's some data showing that some ovarian cancer probably starts in the fallopian tubes. And so it's been American College of OBGYN's recommendations just to remove the fallopian tubes if someone wants a sterilization procedure. So most of the time now we just remove their tubes, whereas in the old days we used to take a segment out. And so there were patients who could have their tubes reversed, where they could have them sewn back together. Nowadays that if you have them removed, they're removed.
Right.
You could still go through in vitro to have more children at that point if you wanted, but you couldn't really have a reversal done. But if you did have just a segment removed, you could have a reversal done. But when we do a sterilization, we counsel patients that it is meant to be permanent and non-reversible.
Got it. So. Okay. Are there any misconceptions that you hear about birth control that you just wish you could tell people, look, this just please don't believe that or whatever? Do you have some that?
Yeah, there are. I mean, there are quite a few, I would say. For one, I think, Dr. Google is pretty prevalent, right? So
for a minute there, I'm like, wait a minute, I have an interview to. Oh, okay.
Yeah, yeah. So people do get a lot of information off the internet, and good or bad. There's a lot of out there that, especially about IUDs. I mean, there's a lot of information out there, and people who have had bad experiences with IUDs, they tend to put that out there, and I would say that people that have great experiences with IUDs don't necessarily put that out there.
Well, generally you don't, because everything worked perfully for you.
Right. So but it's, for one, there's a lot of misconceptions about IUDs. And so for one is that teenagers can have IUDs. And so we advocate for that, teens, reliable birth control for teenagers. I mean, we all know that teens are having sex, and we want them to be on reliable birth control if that's what they're doing. And so we do advocate for these, long-acting contraception. That's something that's reliable and effective. And so it's always about their choice, what type of birth control they want. We counsel them about their choices, but that is an option for them and something that's reliable. So in the way in the old days, IUDs used to be reserved for people who were married, and that's just not true anymore. And so so that's a misconception that they can be used in any patient, really. We always rule out sexually transmitted infections when we're putting them in, but they can be used in anyone. That birth control causes weight gain. That's another one. Women tend to be very sensitive about weight gain.
Yeah.
And so really, Depo-Provera can cause weight gain. There is some truth to that. But most other birth control really does not cause weight gain. And so birth control pills generally are very weight neutral. And, not to say that a patient can't notice some weight gain, but as a whole, they do not cause weight gain. Let's see, what else? I think the biggest thing is really like talking to your provider and knowing that they have the information, and trying not to rely on the internet.
Right. Well, I'm sure there's areas of the internet that you can trust. You could go to Monument Health, you could go to the Mayo Clinic website, but stay off a lot of.
The other one I thought of, was infertility.
Oh, okay.
People worry about infertility, that birth control can cause infertility, and that's not true. Really, almost all birth control, your fertility resumes very shortly after discontinuing. Depo-Provera can cause a delay. There's a time that it will take to get out of your system, but otherwise, most birth control, your fertility resumes pretty much immediately. I think the thing to keep in mind is that people don't really question their fertility until they try and get pregnant. And so some patients will have some infertility. It really has nothing to do with their birth control that they were on previously. So
out of all of the ones that you've listed too, which are the most effective in your opinion?
So the intrauterine devices, so the IUDs for sure are the most effective, and the implant in the arm are the most effective. They're 99+% effective.
Oh, wow.
Just because when you look at birth control, you look at the ideal use versus the ideal use is not the same as the typical use. And so, you can look at studies, and what typical use is always going to be lower than what ideal use is. But with the IUD, it's the same, because the patient doesn't have to do anything. Once it's put in, it's in. And so it's, 99+% effective. And whereas birth control pills, we say are 97 to 99% effective, is ideal use. But typical use is somewhere around 91, 93%.
Oh, wow.
Because people forget to take their pills, and they get sick, or they, maybe they take some medicine that maybe interacts with their pills or something like that. And so they have a little higher failure rate. So.
Okay. Now, being a surgeon too, I've been trying to ask the surgeons that have been on this podcast so far that when you're in surgery and you're in the groove, do you have a playlist of music that you listen to? Something that you absolutely have to have on while you're doing surgery?
I don't have a specific playlist. I like country music, so I listen to country.
Thank goodness.
Yeah.
I think you're the first one that's come in and said, I want to hear country.
Yes, I listen to country music mostly.
Okay.
So the girls will put country on when I'm in the OR usually.
Excellent.
So.
Well, that's the best way I could think to wrap this up then. Dr. Heather Brewer, OBGYN surgeon with the Monument Health Spearfish and Clinic. And you do have some appointments in Sturgis, though, too, I believe.
I do an outreach clinic in Sturgis once a month. Yeah.
Excellent. Well, it was great talking to you. And I know I certainly learned a lot, which isn't saying much. But again, thank you so much for coming in and talking.
Thanks for having me.